It was a middle-aged male presented with angina on existing class 3 case. It was known case of TVT with PTCA done to LAD and circumflex. He refused bypass surgery, and that was what made us to do LAD circumflex, and then RCA-CT was planned as the contrast which was used was a little higher on that day. And injection fraction is 55%. So that is how now we are going live with Dr. Goel and Devapura being there. Over to you, Professor Goel.
Yeah, actually the first thing is you see the plan is to do the right. Now right I usually do with the SAL. The support is better with SAL. Now incidentally we don't have a SAL here, so I have taken a JR. Alright, so I have put the JR on the right, and the JR is with a side hole, and it is 7 French, because CTO usually I like to do with 7 French. You have more flexibility in using hardwares with 7 French. And this has gone through the right radial. You use a glide sheath. You can use 7 French guiding catheters. It's a 6x7 glide sheath with a 6 outer diameter. Inside it takes 7 French. And for contralateral we have the left, which is a 7 French left EBU, which is there through the groin. Okay, so now if can you show me the first angio that you showed of the right coronary, because it was patent till the RV branch, but now it is not patent till the RV branch also. The occlusion was beyond the RV branch. Here if you see the angio, so the RV branch is coming in between. We have the contralateral filling till you have the RV branch and the distal RV branch, big RV branch, and the distal RCA joining together, and the occlusion is much higher. So I wonder, this has occluded. Recently the anatomy has changed probably. So let us see how we go about it. Right now I just have a Sion wire to get my microcatheter in place.
Dr. Goel sir, can you show the angiogram from the first angiogram today, the total angiogram, because we did not see the angio today.
Show the angio. If you can show the, I don't know if the old angio that we had seen sitting outside, if you can show that RCA angio, which will tell us how the RCA looked when the angio was done, but now it's looking totally different. So this is the left injection. The left fills the distal RCA, and then we do the antegrade injection to get the two together. So this shows a very long occlusion although. And show me the next one, the RAO view. So that's RAO type view. Now you have a connection through the PDA from the LAD, but that's round the apex, which is tortuous, and it is epicardial, and it's very long. So I am not very sure if, because this will become so long that maybe the microcatheter will fall short when you have to exit from the opposite side. So this may not be the right option to take, right? And then there is a some small shorter connection from the distal LAD across the so-called septal, but these also become subepicardial when they are very distal. So they do not remain in the septum anymore. That's what the teaching is. So anyhow, we have to give an antegrade try and see what happens. Okay? So I will try for the antegrade first. Okay. Can you show me
Professor Goel, this is Aftab here.
Yeah.
So
can you
just for purpose of learning, so I think it's a tough case there, and especially we don't see much of interventional collaterals from the left.
Yeah.
I mean, that's what at least we can see on the screen here.
Yes, correct.
So the antegrade, your comments on antegrade, your chances of the assessment of the antegrade proximal cap and the
yeah, we will. That's what I am.
The favorable factors there.
You see, this is actually, this was patent. I don't know if how they can show that angio. Can you show that previous angio, the RCA injection before? They can, if they can show it, then only you will understand that, because I have seen that. Now, can I see the RCA injection, please? No, can you inject for me?
Yes, RCA.
Oh, yes. Inject, please. Okay. So I will put the microcatheter there. And can I get this a little closer?
जिस तरफ आगे
थोड़ा सा, हाँ.
So what is your wire escalation technique? What wire have you started off with?
Well, I have right now only a Sion to get my microcatheter in place. Where is the microcatheter? Can you see? I can't see it. Yeah. Just hold on. What is the size? What is this?
Black dot is hanging
Where is
upstairs.
it?
It is entered.
Where is it? Where is the microcatheter? I can't
From
see
Ramdeo asking about the microcatheters
Vision
that
is-
are available.
Can you
Pratap, can you
increase
hear me?
the size? Can you increase the size? Just hold on. Where is the microcatheter? Let me. Just hold on. I do.
Pratap, yeah, there's a
Where
question
is
in the
the
chat box
microcatheter?
by Dr. Ramdeo. He wants to know about the Mamba and the Turnpike LP. So have you had a chance to use them in India? Do you have the Mamba in India?
Yeah, Turnpike
Uh,
LP is actually not available till today in India, but this
Oh.
Teleflex actually bringing already Turnpike LP, but I used in
Okay.
one of the international center, Malaysia, when I went at the angioplasty, I used Turnpike. Turnpike is a very good catheter. It is almost like our fine cross,
Actually, the
but
support of RC is very bad. You don't have a SAL at all, huh?
no, it is not. There is no SAL, Dr. Goel here.
Because I only work through SAL.
I know. Actually, SAL actually has an excellent catheter, especially in these type of cases, where you cannot use an Amplat's full AL1 also.
No, you can't use a full AL1.
That is what is the most important thing, because it can damage the ostium. Number one, number two, your SAL is a very good catheter in these cases. And after can actually the catheter available Turnpike LP is almost like a very good catheter, especially for the tortuous anatomy in the retrograde collaterals.
Give me a
septal channel.
XTR or something. Come on. Give me
But
XTR.
it-
Now at this stage, my choice would have been a XT plane because
Which
XT
is
find
a
its.
it's a fine cross.
I put the fine cross there. Yeah. Give me a XTR. I think they don't have a XT. I love to use a XT because XT you can't direct it, but it finds its way when the lesion is soft. Because I am sure this part is soft, so I would have preferred a.
You'll be taking an XTA, right?
Well, not XTA. I'm using a XTR because this is a soft lesion here, if I'm not wrong.
The
Because
angiogram, I think, was done quite a long back, I think 6 months back. So maybe
Acha, it was done 6
it's not
months
that
back.
long then. So, XTA,
Okay.
Whatever you have seen earlier may not be that easy.
Okay. I thought it was a current angiogram.
No.
Dilip,
Let us see. Let us see.
if there's
Never
something
mind.
that we could do about the screen, Dilip, we have 3 screens there. I think most of us cannot see the full screen of the angiogram. So if you can get rid of the hemodynamic and keep the angiogram film as a bigger screen.
I'm telling you.
Wire. Let the wire come. There it comes. Okay. Give me.
They
Get it
made the
here.
full
Get it
hemodynamic
here.
screen.
Ah.
Okay.
Tight. Really tight so that okay, that's fine. Can I increase the height of the table slightly?
Very good. Dr. Professor Goel, actually,
Yeah.
will you put an anchor wire now before?
No, not now. Just hold on.
Okay. That is one option I wanted to tell after Khan. We will just put an anchor wire. If it is a 7 French, you can put an anchor wire and then do. But only one important point is actually you should not damage the side branch. But he is very comfortable in actually taking a microcatheter with that. If that is not working out, he can take it.
Yeah, the other point for our fellows who may be joining, and I think it's important to understand that you first take a workhouse wire to get to the proximal cap. Do not use your crossing wire to get to the proximal cap, because if you take an XT and try and traverse the proximal cap of the proximal part of your artery to reach the proximal cap, you would probably end up damaging the reach the proximal part and then exchange for your crossing wire.
Actually, I have given a talk on the cost-effective in CTO intervention, where I tell that You can use an aux wire to take up to the proximal cap, then remove that, and then try with the wires where Dr. Goel actually does not want to make a bigger bend. In that situation, a smaller bend, 1 to 2 millimeters and 15-degree angle. In that situation, you should not use a wire to damage in the proximal part itself. You should be just exactly near to the CTO segment. You start with the good wires or the CTO wires. I think, can you show the images, angiogram images?
Can you show me the angio, please? Angio, please. Angio injection. Be ready.
Idea would be I've gone directly with the dia wire. I feel that is a long chronic segment and there is no kind of dimple there where there is no kind of visible channel or perceptible channel. So what is your idea, Dr. Pratap? What is your first choice of wire in this case?
No, actually,
this will not go.
Even with the
this
toughest CTO, sometimes Dr. Goel actually was telling in the morning, if you analyze angiogram properly, you may cross.
Give me a Gaia one.
Wires. Now he is actually taking a Gaia one. My choice of wire is Gaia second directly, but there are actually the people's preference to be important. So the wire choices, he started with the XTA was his choice, but he was not getting, so he tried XTR. Now he is going with the Gaia first.
Gaia.
After Gaia first, he will go to the next escalation. Is actually, it is actually escalation technique after.
Yeah. Pratap, again, there's a question in the chat box from Dr. Ramdev. He's been pretty busy since morning when he's been with us and putting all these questions up. He's asked, why don't we switch on to implants first? Why do we not try implants, especially when you don't have?
That is what actually he was feeling very importantly. He was actually wanted a short implants.
Short implants would have been the best catheter because all these things support is most important. Because several lesions, like I was talking today morning to Pratap, that case, the little guideliner going inside, I could put a balloon and no microcatheter, nothing could cross after the balloon had crossed a CTO lesion. So support is most important. You get it? So let us see, because this catheter always was coming out. It is at least hanging there. Okay.
AL1 is actually one catheter after many people try, but actually this angulation of the vessel is like it is a very good catheter. SAL. He was actually in the first thing, he was actually asking everybody, can I get SAL or not?
Sure.
Oops. Now this side branch is creating.
So that again brings up this point. I think the CTO, when you are attempting a CTO case, why we tell you to do an ad hoc and never do it ad hoc and always do it as a planned procedure is that you get your material stuff ready before you proceed. And this is what the reason why everywhere we discourage doing an ad hoc procedure for a CTO.
No, after actually many cath labs does not have a SAL catheter all the time, but actually. Dr. Goel is used to SAL and then he is actually very familiar most of the time. This is very important for an operator also. When he is familiar with something, that will be the ideal catheter. If you actually call AV Mehta, he will tell, I will never use an XP catheter, only EBU, because XP and EBU you can use both together, both easily. But for an operator, comfort is also important, especially when you work in another lab.
Yeah, sure.
What about AR catheters? Like
this has become a tough occlusion actually. It's I thought it was soft. It is not so. So what I need is a Gaia 2 or Conquest. Gaia 2 you have?
Dr. Goel?
Give me Gaia 2. Yeah.
Dr. Goel, there have a question actually. Anytime you use an AR catheter, I don't use, but what is your opinion?
Well, AR, sometimes if the SAL is becoming big for that aorta, then AR2 or AR1 could also work. But what we need is a Amplats type of a curve, and regular AL is too big for a right coronary, that is sure. So SAL works largely. This is Gaia 2?
Gaia 2.
New York?
New York.
Okay.
When the angulation is very good for a JR catheter, SAL will work very nicely.
The other thing I can do is, if this branch is creating problem, I can occlude this branch with a balloon.
There is anchor balloon technique. Actually, it is work but we have to take only a 2 millimeter maximum. You can take 1.5 or 2 because the vessel is not that big as an anchor vessel side branch.
So it gives you both the things. So an anchor balloon would probably occlude the branch for you to get into the lumen and also provide the unnecessary support possibly.
Correct. Number one, actually, Aftab, is very, very important for every fellows to understand that when we do an anchor balloon technique, we should always see that it is 1:1 ratio, definitely not lower or higher, and not high pressure also, because you should not dissect the vessel. Sometimes you will
so again, yeah.
Tell me after.
So you've taken a Gaia second now to escalate. So again, the question that normally many of our people would have is that we do have a tendency to shape our wires, but Gaia second already comes with or the Gaia series already comes with a pre-shaped tip. How often do you need to reshape your Gaia wires?
I think Goel sir, you can.
I don't reshape them. I don't reshape them.
I don't also reshape. Actually, reshape. Right. The principle actually, whoever manufactured the Gaia is actually coming from Kenyan Asus. Was the man behind this Gaia wires and Gaia next wires. He was telling if you reshape it, whatever his tendency was gone away. I think there is a small progression in the vessel now. The wire is little progressing.
No, it's coming back.
Not an easy.
Side support is unfortunately.
Get an angle to it. Just a sec.
After it is not an easy one, you know that actually the side branch also creates.
I understand.
I will tell this actually the chance of success in these type of cases actually maximum 60%, right? Not more than that, because all the negative things are there.
Right.
The side branch occlusion, long occlusion, more than 20 millimeters, little tortuosity, and everything is against this favorable anatomy.
So the perfect case to be kept for a life case, yeah.
No. No, it is actually after any operator wanted to. You don't know when we are actually doing IJCT or me and Dr. Goel, we know that whenever we are keeping these tough cases for the Japanese, they will pick the best of the best and then show it to everybody, and people will feel that we are failing, they are successful, not because of that. They take the best out of that.
I understand. Yeah.
And they, but
it's
they
really
know
very
how
tough, yeah. I am
very
pushing it hard against the plaque, but it is not moving forward.
I think Goel sir actually.
So how long do you spend time with your wire before you escalate again? What is your normal conventional time frame?
It depends. Not too long.
Yeah.
At the same time, sometimes you may think that you are crossing. Now there is definitely there is a progress. Progress created, no doubt about it.
Definitely, yeah.
How long?
No, girls have actually progressed very nicely now. I personally feel that only thing is the catheter support is not good. Catheter is a little bit backing out, but he progressed it.
So how long would be the strategy of continuing with chance of crossing duration 15 minutes, 20 minutes?
No. Now it is actually he started moving up. Now he will not leave it. If it is not moving, then he will take a chance. But the only thing is actually if the microcatheter can be moved some more distally, it will be very easy for him. But I don't think that microcatheter will go down.
Yeah, I think probably he is already at the proximal cap with the micro.
But it is not. Actually, can you show the images? They are not showing the images. Just tell them to show the images.
Can I see an RAO? Can you make it RAO? Can you make it RAO?
RAO. This is very important point actually what Dr. Goel sir is doing actually, because you have to change the projection to understand that whether you are in the luminal side or not.
Left injection, please.
Ready,
sir.
Integrate only
left injection, yes.
Two important points. One, you have to see that whether you are in the line or the vessel or not. Number two, you should not inject antigrade and create a dissection.
Okay.
In line with the vessel.
Right.
You personally believe you are in the line with the vessel.
I think at this moment, the RO projection is not helping us. I think we can go
No,
back to
no,
daily
it is
view.
helping you a lot, man. I'm sorry to say that.
Yeah.
Because I have to
Yeah.
make sure that when I am going in LAO, I am not going haywire in RAO. Always view in two orthogonal views. This is a
Great.
bottom line. Then only you know where
Yeah.
you are. So,
Especially when a person who is always well versed with the high, what is this? What is this called? He has a cath lab which is actually having a
biplane.
pipeline cath
Biplane.
lab. Sorry, I'm not getting the word. Actually, becoming old man,
Pratap, you are
So that
becoming
wire
old,
seems to be moving in a good direction now. So that
Very
looks
good.
pretty positive
Very
now.
good.
Yeah.
I think you should show the angio now. We are, Aftab's face is very good, but actually we are there showing only Aftab's face.
So, so I think they are more interested in looking at. So there's again a question from Dr. Rao. So they wish that they can see the cath lab bigger, the online screen bigger, and they can probably cut down the hemodynamic frame. And Dr. Goel, I think people they know him well, so his voice is good enough for us. But you can see the screen better because on the camera, on the devices, the screen is pretty small.
So it seems I am going in the right direction. That is
that's a wonderful progression. So I think this view was wonderfully good.
LAO, please, because I have the controls with me, so I rotate it because LAO, please.
The other thing we also want to see in this view is your guide cath orientation. So sometimes you are pushing sometimes, and if your guide cath is reoriented in a different way, especially in the right coronary artery, you could probably be pushing and you would not make headways. So in RO, we would also look at the orientation of a guide cath to know whether you're in the right, well oriented.
Left injection, please. Okay, so now I am heading a little backwards, so I have to change it, huh?
So the advantage with this Gaia series is the fact that they are good to come back and re-enter, unlike the other wires that we sometimes, once you create a false passage, it's difficult to reorient into the true passage. So I think the Gaia series has really made a difference for anyone who uses it to understand that it's a great wire, and it has really increased our control of the distal wire.
After we always tell it is a redirectional wire. Actually, you can redirect the wire into any angle you want. And especially Gaia Next is a very good series of wire, especially in a severely fibrotic lesion. This Gaia can be broken inside. Gaia Next will not be broken.
Right.
I think there is a very good progress is making by Dr. Goel. Actually, I think she's not seeing the angiogram. Can you just show the angio?
So the transmission team, again, the same request. If you've moved on to the speaker view on our devices, but we still see the same 3 frames. We really don't need to see all the 3 frames, and the angiogram image is all that we need to see. So again, I think Dr. Ramdev has a question. How often do you go lateral to have a look at your right coronary artery, or are you happy with an LO and an RO? So lateral, sometimes it does become difficult, especially you're doing radial and you're doing the other procedures to move your tube so much.
Can I make it a little bigger, please? Can I make
lateral
it a
sometimes,
little bigger?
but the conventional routes would only be RO and LO.
Okay. No,
Only
bigger, huh?
Only the angiogram. You just tell that no speaker to be shown, only the angiogram. Only the camera.
Okay, what is happening, Pratap?
I don't know. I think they are not understanding what we are talking.
No, it seems that whenever anyone is speaking, their face is getting displayed onto the screen. So I think we need to get rid of that feature there.
Actually, I need a tougher wire here. It is not penetrating the distal cap. I am very close to the distal cap.
Proximal cap was easily gone, but the distal cap is actually having a tough time, and moreover, it is taking a difficult angulation. But you could, Dr. Goel, could you take the microcatheter down or not?
It is not going down. My guiding is backing out. LAO back. At this stage, if I could advance my microcatheter, it would be very good. You see,
So, Pratap, any specific choices of microcatheters that you would prefer? Fine cross is usually most of us.
If there is a difficult situation like this, I usually take fine cross only. Corsair Pro is also very good, but this case Caravel is definitely not a good choice. That's very, very important. Caravel is a good choice only in the septal channel crossing, not for this type of lesion crossing, where either a fine cross or a turnpike spiral is a very good one, which is not available in our place. And the third situation is actually Corsair Pro, not Corsair Pro, Corsair Pro XS. I think they are not showing the angiogram. He is actually crossed nicely. Can you just show the angiogram?
Left injection, please. Yeah, it seems.
Progress now. The direction is not comfortable for, now the direction is good. Changing the direction now. Yes, I think it is crossed.
I don't know.
Crossed.
Let us see.
No, it is crossed. Wire movement is
left injection, left injection.
went into the side branch, not in the main vessel, but it is okay.
Yes.
Yes.
Boom. You see, so that is the boom, huh? So now we'll do something. Okay. So now I'll talk a little. You see, in this crossing.
Now there is no Pradhavis will not talk. Only you talk.
No, you see, the issue here was first to enter that occlusion with the side branch in front, right? The side branch being there, every time I was going in the side branch. So one way is to occlude the side branch with a balloon, and then the other is you use a tougher wire. Now Gaia 2 is not a easy wire. It's not a very soft wire, I can tell you. It's less than Gaia 3, but it is very strong. So I entered, and then I manage my track by seeing in biplane. I'll LAO, and then soon I see RAO, because I have to sometimes use, like you said, gone. I said yes, gone, but cannot be certain, because sometimes it looks that it is gone through, but in the other view it is miles away. So and then you are somewhere wrong. So you keep tracking it in the two tracks, and then your microcatheter moves forward, gives you a little more support. And because this support is the biggest thing in CTO crossing, I tell you. If you imagine an artery, just think about the artery. After all, it's an occlusion, it's not that hard. Yeah, when wires go, only thing is if I sit at the mouth of the occlusion and push, I'll always push. So that microcatheter I advanced, and then it moved. And at the last point, when the distal cap was there, I was always directing, Pratap caught those directions, he was dictating it. That's perfectly right. And this actually I have learned more and more after, since I have published that article on 3D wiring. So principally I am doing that concept, it's a concept that you understand where the wire is in relation to the artery and where the angle, the tip of the wire is in relation to the wire. And then you direct it. Well, that is theoretical, but practically everyone does that. I have just conceptualized it, and with that, this technique has become more stronger. And CTO.
Along the CTO and the way you took the wire.
So now what I'll do, I will not get it back. The other principle that I always follow: if you are in a side branch and you know that you are through the lesion, you have crossed the lesion and you are in side branch, don't get it back, because this wire you may not able to get it back into the other artery now. So best is let it move forward in this branch, work on this branch, open it through a small balloon channel, and once it opens, then you will get the track to the main artery. You get it? So I will now further advance it because I need little more wire inside for supports. So RAO shows it better. RAO. You see my hand is always going reflexly here because that is where the rotation is supposed to be with me.
Control with you, sir.
Yes, I always have the control with me. So now you see the arrow shows it more straight and this thing. So because this is a tough wire at the tip, I don't want it to. Show me the left injection, please.
The branch is of a good size, so that gives you that much of leverage. Yeah.
Yeah, unlock the thing, please. Table, huh?
So Dilip, while the tough part is through, can you just tell us what fluoro settings have you kept, and basically for many of our colleagues here, the radiation protection that you would want us to take when you're doing cases like this?
Okay.
Yeah, I think
Now, if the micro goes in, I can change the wire. If it doesn't go in, I have to dial it. Go back to LAO. This is the time I need more support from the guiding also. I don't know how much support I'll get.
so. What I can make out from here, it is standard setting only. I think we can go with the lesser frame rates. We can definitely go with that. So I will precisely tell you once I inquire.
Is backing out. You saw that?
Yes, sir.
Yeah.
So that's very. So once I'm in the patent part, I'll use a Sion wire. Angio, please. Let me ensure that I'm in the patent part. Sion, Angio, please. Yeah, come on. Okay, so I have crossed that part. Huh? So I'll now change the wire.
The branch.
Now, give me that Sion wire.
So Professor Goel, just a query. Yeah. Now you had a microcatheter in the proximal part of the, after you had crossed the proximal cap. And we saw that even though you had not crossed the distal cap, there was an advancement of the catheter that was made. So what makes you feel that at what stage should you advance your microcatheter without being in the distal part of the vessel?
Once I have some amount of wire inside, it should give support.
Dr. Goel, do you have a problem of taking the microcatheter down? It was easy?
Well, initially it was not easy. You saw I got stuck about 10 millimeter below the occlusion. But then my wire moved forward and then I went into the branch and then it was success crossed. Once the wire is in, now the second part when I moved the microcatheter till the division, it was easy. Okay?
I know,
but the initial was very tough. Initial was very tough.
Actually, Aftab Khan, I wanted to tell you, in these type of cases, ideal situation that Japanese can do, we also do, because we would take a corsair to take the second wire to the other branch. Now, see, we are actually used not to spend more money, so we know what we. But ideal situation is taken a corsair, crusade, and then take two wires in two branches.
A double lumen catheter is, I think, what.
But crusade is a big volume, big profile. RAO, please.
Yeah.
No, you can do a balloon in the proximal part and then crusade in the distal segment and then take a balloon wire to the other branch.
Hold on.
Or I think even if you're doing a dilatation, one would want to stay away from the bifurcation so that you don't close off the parent branch. That's what I think.
No, actually, he shifted the wire to fan. Soft wire. Now he will be dilating easily. Now do you use a balloon trap?
Yeah, I need no. I'll now balloon trap to remove the microcatheter. Balloon trap, please. Actually, Pratap, I am a anti-grade man. I have realized. I do always anti-grade. I find out anti-grade way, and if I fail anti-grade, I will do Stingray and succeed in anti-grade. You understand?
I know that. I know.
So I have.
No. This angiogram you don't know. Goel sir, before itself I told Dilip, you don't know. Dr. Goel will cross anti-grade and will show the technique also.
Yes.
And I was telling him beforehand. Now he is telling correctly. I predicted. I know that you're still. That here the toughest situation was the proximal cap. Then switching over to the as Aftab Khan told, the redirecting the wire, that was an ideal situation in this case,
And so Gaia gets redirected beautifully, So
that last one was, people were asking why you did not use a Gaia 3 wire.
no, no,
Can
no.
you just
You see, I'll tell you what. Gaia 3, I need a control on the wire. Gaia 3 will move like makhan ki tarah jayega, aur wo jo hai, you don't know where the damn thing will go. It's like a very fine knife, you understand, or needle.
It's like a
It-
needle, you
yes,
said.
it will just go, and you will feel you are in that direction. It will go boom. So we have to
these
be
are all
very careful. These
actually
wire
after
manipulations, I see, they look simple or whatever they look, but they are very fine manipulations. Very, very fine, I can tell you. You
Can I
can
ask?
So I think what Dr. Goel is also trying to refer to is the
Exactly.
feel of the distal tip of the wire. This is something that you can only learn by feeling, by doing these cases.
Yeah,
It's
yeah.
very
More,
difficult
and
to tell
it comes
you
by
what
experience.
exactly is a.
It
yeah.
comes by experience, and well, everyone will gain experience, I'm
actually
sure.
when
Ek
he
second.
crossed, even Dr.
Trap,
Goel, me,
trap.
after understood the wire is in the distal
16.
lumen, but as an operator, Dr. Goel was telling that, let me see.
Yeah, because I have seen these wires bloody go haywire, yeah. I have seen them.
I know that he will not agree for that till he see by himself by
Yes.
angiography.
Seeing is believing, I believe in that statement. Seeing is, you see what you, other thing is, you see what you know. One statement is this, and second is seeing is believing. Okay?
So Mary,
Just for a hypothetical case, Pratap, if you did not, if Dr. Goel, God forbid,
Now I
did not do
need
it
a
antegrately and had to go to a
1.215
retrograde
millimeter
approach,
long balloon.
how would your assessment of your retrograde channels be in this case?
You are asking Pratap. Pratap, you address that. Because my thought was the one round the apex is too long. And the length is also important, because if I am just left with the hub of the microcatheter to go inside of that 150 also, if I use a very long channel, then that microcatheter also falls short sometimes. And this is
Actually,
the problem with the around the apex microchannels.
Yeah, after actually the retrograde channel that
I need
was
longer
almost
one.
like an epicardial channel
15,
from the
20,
apex.
15.
If you wanted to take that, you have to cut short the
15,
catheter to
20.
97. That's the only way.
Huh?
So you have to cut short
Sorry?
EBU catheter, induce 90 centimeters.
1.2 or 1.5, 12,
Otherwise,
15,
take a short catheter.
1.2,
90
12. Okay.
centimeters short catheter. But it was a clear-cut demonstration of how even a very, very difficult looking CTO, how it can be crossed. And actually it was only wire escalation technique. He just started with a XTR, which his favorite wire was XTA, which I know. And the second wire, he has taken a Gaia first. Then he tried Gaia first. Actually, this is the important positive. People ask Gaia 3 why. He was going very, very slowly, not to take a very tough wire to create a damage in the system. So if you do an IVUS in this case, you can see that it will be totally true luminary.
Yes.
so are you going to do IVUS, Mr. Goel here?
Yeah.
I
Yeah,
think
please.
better to do an IVUS and demonstrate that it is truly luminary. I don't know whether why this image is not. Okay.
You see how it is moving? I am not moving it. You see that? I am only standing like this.
No.
And it is moving.
Then you, Goel sir, you stand 10 meters away. Then let us see whether it will move automatically. He will tell all these things. Don't believe, he is doing everything by his hand.
Bhaiya, tum karo.
It is 1.5 or 1.25.
This is 1.2. Actually, I didn't want to take a chance that 1.5 doesn't go. Okay. And inflate.
After what I do is actually when a microcatheter can cross, we can.
Yeah,
yeah, I know.
microcatheter is a
I know.
1.8.
This
so
is just
probably you would want to
playing.
get
This
about
is just playing a little more safe. That's all. At the most, I'll use one more balloon. That's all. I don't. No worries. Down. Down, please.
In a live case and all, we should not. Actually, our catheter is backing out, sir.
No. I'm controlling it.
Okay.
Balloon inflation, please.
I think now if you want, you can keep a anchor wire, not even a balloon, but one more wire in the distal vessel is also good, or in the side branch
Go
also,
down.
so that your catheter will be more stabilized.
Probably could use a guideliner also, or a guideliner to get yourself a bit more by there.
Down. Balloon, please. Down. Go up. Up more. It's not opening, is it? Down. Down.
Because the proximal cap was the toughest cap what he felt. So that is why he wanted to create his
Balloon. Down.
I think this balloon is ruptured.
I don't know.
No, sure.
Let us see.
So Pratap, whilst Professor Goel is working, I was just speaking to Dilip and asking him. I think radiation protection is also an important thing for a cath lab staff.
Actually,
and
this
for the patient and the
should
thing.
be radiolucent. That's why I kept it away, because you should be able to see the patient.
Right. So what are
Come
the
on,
things that you do in your
please,
cath lab to make sure that you reduce the risk of radiation to the patient and to the staff?
No. Now we need an antigrade. Now we need here.
Very hard
You
to
see, now
inject
you see, I asked him to inject. He injected left. Now left will not work anymore. The left has done its part. Now you have to inject right, because now it is antigrade. So it will not fill through the left anymore. Okay. Come on. Yes.
As high as possible. And
So
frame rate they have
now
kept
the antigrade
in-
flow is there.
last time,
I need a 2.5 balloon.
Correct. 2.5 to dilate. Actually,
the proximal cap. Actually, the proximal cap, and then now when I need to wire the distal vessel, I might use a crusade. You see,
that is
one-
the same thing. Ideally, a crusade to take, but the proximal vessel to be dilated first. Then
yes.
wait for the crusade.
2.5, please. Come on. Proximal. 2.5, 12.
So what's our anticoagulation strategy as yet?
ACT.
What has been your
Basically, I've checked,
anticoagulation
it was
as
451.
Okay.
15
If you
minutes
want
back,
to
I've
remove
given 1000 more.
Okay.
Actually, Goel sir, will you remove the left catheter now?
Yeah, I will. Let me just dilate this one, and then I will remove.
Correct. Because then why people will just
Yeah.
moving the other catheter, creating a
Yeah,
problem.
certainly.
You can keep the BP monitoring it from the sheath itself. You don't
Yes.
have to. Catheter.
The other thing we do is to remove the injector syringe from the catheter that you don't want to inject. So once you've got antigrade, we just remove the syringe from the retrograde,
उसको आगे ले आओ.
so that don't keep on injecting into the antigrade or the retrograde whenever you don't want it to be.
Correct. Now it is a very, very important example actually where he wanted an injection from the right system, but the injection came from the left system.
Come on, test please. Small test from the right. Okay, come on, inflate. Oh, hold on. Okay. Keeps it. This is 15 mm?
This is 14, sir.
No. The balloon?
12
Down,
millimeter.
down,
12 millimeter.
down. It is 12?
I think it's 12.
Balloon.
Another important point actually Dr. Goel is actually telling, people may inflate and deflate immediately. No, you should give some space, some time for the vessel
Down.
to get opened up.
Down.
After this, actually all the young generation is like that. They just inflate and deflate in 2 seconds.
Yeah. Test, inflate please.
Well, I remember in the old generations when you do not have the Johnson stents, you put a timer on and wait for 90 seconds and then deflate your stents also.
Earlier actually what Dr. Matt and all telling that 5 minutes, 7 minutes, they keep inflate till the people get a
Well,
pain.
those days we used to keep it inflated for 1 minute at least. But
2 minutes.
still, you know, there are, I use that technique sometimes when I have to leave a distal lesion on balloon only. And even otherwise, you know, if you give a little longer inflation and deflate it also slowly rather than boom, you release it. No. What happens is that immediate release can suck out the wall and produce a dissection. So if you release it slowly, whatever you've done, tacks it up and gives you a better result.
I think the DEB balloon
Come
is
on.
bringing back those
Angio, please.
techniques again. So when you're using your DEB, I think you're back to those old techniques of prolonged balloon
Okay,
inflations
okay.
now.
I think, Goel
What
sir,
I
we
can
try
do,
wire without even a crusade.
yes, that's what I was thinking. Give me a New York Sion wire, please. No, but I will.
Just try once. and if
You
it
have a
works,
crusade? You have a crusade, to hoga? Huh? You don't have crusade?
No.
Give me a 1.5 or 2 balloon. एक 2 का balloon दो यहाँ थोड़ा सा dilate कर दें, then it will be okay.
So I think just before the bifurcation, you probably
I
want
want,
to just
yeah,
take a little space for the
little
wire
more
to move
space.
around.
Yes, a little more space. But I don't want to overdo on the space. Sometimes what happens if you overdo
Right.
on that space, you occlude the distal vessels.
Yes. So you probably want to just take proximal to the bifurcation and not make a big dilatation
yes,
also
not too
to
big.
create, avoid
So
creating
that's
a
why I
dissection
want
there.
a
I think
2
those are
mm.
important
2
points.
mm दो एक.
बात करेगा पेशेंट सर.
Is he
One
okay?
more important thing I just wanted to tell after. Here the bifurcation.
ला जल्दी दो 2
the
mm. हाँ.
filling of the distal vessel was actually from the up to the bifurcation. That is not a good place even for retrograde wire to enter inside.
कौन सा वाला
Sure,
है?
sure.
If it is an exactly the bifurcation, PLV junction is occluded.
हाँ
And there is
लाओ मेरे को
tightening.
दो ना भाई 2 mm बैलून दे दो ना. अरे 2 का नहीं है. 2 का दे दो. ऑक्सफोर्ड दे दो. मुझे 2 का बैलून दे दो यार.
एस्टिमेट कर दो.
हाँ वो अभी खोला है, वो अभी हो जाएगा. गिव मी अ 20 बैलून. हाँ.
Ox and O. New York and Oxford is also one.
You don't have a crusade ना?
फ्लूइड
I think you
Fluid
can.
दो थोड़ा.
No. He wanted to demonstrate if there is no possibility.
एंजो करो.
I know that he will easily cross to the side branch immediately, but
Just
he
hold
wanted to
on.
demonstrate
Come
how
on.
a crusade to be used properly.
एक सेकंड जस्ट होल्ड ऑन. वो हैंग मूव कर रहा है ना. मुझे वो दो ना. मुझे 20 बैलून दे दो यार कोई. थोड़ा आईवी फ्लूइड दो थोड़ा.
जेट 50.
दिस इज 20 हाँ.
20.
गिव मी अ न्यूयॉर्क सियॉन वायर. कम ऑन. लाओ. अच्छा मेरे को सियॉन वायर. कम ऑन बाबू, मेरे को सियॉन वायर दो. गिव मी अ न्यूयॉर्क सियॉन वायर. लेफ्ट सिस्टम इज ओके ना.
Goel sir, only 10 minutes more actually.
हाँ. अब भाई अब मैं इसको कंप्लीट करा दूंगा और क्या होगा. बिकॉज
Moreover, are you
Because the
planning
main-
to do or not?
गिव मी अ 20 बैलून प्लीज. अच्छा.
So I think the main work is done. It's probably just the wiring. If you can just show us the wiring into the two lumen, into the distal vessel.
But actually there are
Then we
two
could
things and I
come
was
back to
भाई
it.
इसको थोड़ा फ्लूइड दो भाई. एक्चुअली
fluid.
बीपी थोड़ा इसका कम दिख रहा है मेरे को, पता नहीं क्यों.
I think you can remove the RCA left catheter.
वो मैंने निकाल दिए हैं. छोड़ो. Leave it please.
Why this is important in these cases, you know? You don't know heparin
Give
is
some
given how much
NORAD.
heparin is given properly. Dr. Goel sir, you can check them that whether heparin is given correctly. Or
Yes sir, we have checked the ACT.
एट्रोपिन दे दो. मुझे एक माइक्रो.
So I think some fluids and atropine is the usual way to get it come.
मुझे 20 का एक बैलून दे दो ना. नहीं इट इज ओके. मुझे एक डायग्नोस्टिक कैथेटर दो लेफ्ट का.
JL 3.5.
मुझे एक 20 का बैलून दे दो. मुझे एक 20 का बैलून दे दो. गिव मी अ 20 बैलून प्लीज.
एट्रोपिन 1 ampule please. NORAD 2 mics.
नॉरैड 10 पे शुरू कर दो. 10 पे शुरू कर दो. 10 ml per hour with single
So
ampule.
there's a little contrast staining in the distal part. I think that's the previous shoot that is
Uh-huh.
left some contrast in the distal RCA. So I think just volume and increasing the heart rate would probably get rid of that.
थोड़ा फ्लूइड दो भाई उसको.
जेट पे देखो सर.
और दो. एट्रोपिन दो.
So Pratap, how often do you use radiation,
Come on.
the rat pads and
Test
other things
karo.
for cases where you
Test
anticipate a long procedure?
Okay.
After I don't
Inflate.
use
Don't
it.
use
Come on,
rat pads.
inflate.
But
For that
actually,
gentleman that you used 11 grays, I think those
Yeah.
are the guys you'd want to come back and see whether they've had a skin lesion. You'd probably call
Yeah.
them some weeks back and
Always-
have a look at them.
always we look at the patient, but actually I don't look at me. But actually
Yeah.
it is not I think after told it's a very important point. If the distal vessel,
Well, that's
especially
okay. It will be okay.
the PLV has some.
You don't have a crusade. I'm surprised. हाँ?
फ्लोर हो रहा है सर.
कोई बात नहीं.
not every cath lab in the country. You should don't remember when I did an IGCT on one live case from Apollo Hyderabad. when I was asking crusade, they gave me a corset.
ठीक है. Pressure.
Here,
is okay.
people
All
hope
right.
that
All
crusade
right.
and corset.
Now, give me that. Give me a wire, Sion. Sion wire, please. Allow.
So I think we just saw a professor trying to take another wire, but he was bucking at the proximal port. This is where I think a crusade would have been useful.
I need a new wire, new Sion wire. हाँ वो खराब हो गई है. I need a new wire. I need a new wire. लाओ हटाओ उसको.
So
Come on.
CTO interventions are expensive. One has to keep
Yeah,
all,
yeah. You can't sort of economize
yes,
on
cannot,
the.
yes.
You
cannot,
adjust. You
You have
adjust
to use new
your.
balloons. Yes. Yes.
You can adjust them. You know that is an internal matter, but you can't economize.
And not only for
I
success,
have
it's
the
also important for patient safety, I think. Yeah, that's
I have
important
the
to understand.
capacity of using 10 balloons in a case. 10 balloons, 12 wires. But I'll use them.
Anish started or not? Anish. കുഴപ്പമില്ല അപ്പൊ ഞാൻ പിന്നെ അപ്പം വരാം ഞാൻ കൽക്കട്ടയിൽ ഇരിക്കുക ശരി കുഴപ്പമില്ല ആ സമയത്ത് ലൈവിന് കയറുമെന്ന് അറിയത്തില്ല ഞാൻ നോക്കാം അല്ലെങ്കിൽ ഞാൻ കാണാം ആരെങ്കിലും ചോദിക്കാതെ പറഞ്ഞാൽ മതി ഞാൻ ട്രൈ ചെയ്ത് കയറാനെന്ന്
No, Bandhu.
So that contrast is washed out now. So that's.
That indicates the heart rate has gone up. I think the heart rate has gone up.
Yes.
I could not see the heart rate, but definitely the heart rate gone up. This is one important point. When you do an RCS CTO, sometimes the patient heart rate will come down and you will be in a trouble situation. You may think that there is a perforation and all, but it is, when the heart rate goes up, everything will be okay.
So Pratap, while professor's working, one more question for you. There's a question in the chat box. How do you budget for how do you counsel your patients for the budget of a CTO case?
Usually, whenever I do an angioplasty in my hospital for a CTO, I tell the patient minimum 1 lakh to be charged extra than the normal 1 lakh extra. Why I am telling 1 lakh charge extra basically, even if the patient is not having that many materials used, that 1 lakh will be given for the patient. So we always calculate that minimum
2,000 more heparin, 3,000
extra.
Heparin ले दो heparin.
3,000.
So that is.
We have
So,
crusade catheter they are giving.
Crusade
No.
is given now.
Crusade has
Crusade.
come.
Trupti,
Now,
3,000.
because you know you
doc-
need all these things. Come on, Crusade दे दो.
165.
No, Goel sir, we should demonstrate that how the wire goes from the crusade middle, that part. You please show that. After that, we will be off the live for some time if there is a discussion or some cases and all. That is the most important step. He wanted to demonstrate a crusade to people.
So I don't think so. The camera guys could have a zoom there, but I think
Can you just show the
Goel can tell us what is the thing. Yeah.
Goel sir, you have taken the
Tell us where
crusade.
the
that is there.
yes. Tell us where the wire exits and
angio,
the other
please.
wire gets in.
Angio, please.
Because
Because
just focus on part,
sorry,
two markers.
angio, So there is a distal marker and
Let him
there
get
is
it
a
down and then I
fainter.
think
It's
he'll probably
already
tell us,
there.
yeah.
So I will put it right there. Okay. Now give me the wire. Give me a Sion wire. If it is patent, Sion will go.
After you should explain that there are two markers, the proximal and the
yes.
distal marker.
Yes.
The distal marker is
Yeah.
more.
So the distal marker actually is on the wire that you've gone through, which is usually either the side branch
The
or the parent
proximal
branch.
marker
And this
is
a
where
monorail.
the other wire will exit. This is a
Between
Sion
the
wire I
proximal
have
is
taken because I think it is patent. So torquer, please. Torquer on this. So it has gone monorail. It goes monorail inside first. Tight.
So the distal marker comes out as a rapid exchange, and the proximal marker is what comes out as from the hub as a monorail.
Make it RO, please.
Yeah.
There
Yeah,
we
you're
go.
through then. Yes.
You saw that
So
the
this
wire
makes
goes
things
in.
very easy, you know. Now the issue is to get it out. Now I have a 7
Yes.
French, so I can trap it. If I
No, you
this
can
is
trap
wha-
with
no no
No, you can
let
try with
me
the same 2.5 balloon.
yeah
you take
no. Sorry sorry to I wanted to say something. Had it been a 6 French guide, I could not have trapped the crusade.
Okay.
That is what I wanted to say. That is one of the limitations of a 6 French system in CTO. You cannot trap a crusade. Actually, there are 3 or 4 limitations. So one has to know them exactly. You see.
Right. So
now
when
I
you're using
pulled
a
it
7
back,
French,
but
usually
now,
a 2
now
or a
I can
2.5
trap
balloon
it.
is
Now
good
I
enough.
can trap it, no problem.
But for an 8 French, probably you need to go at least 2.5 or a 3.
See, usually after
No,
I
not
always
2.
take a
2.5.
2.5.
2.5.
2.5 is ideal.
Don't
2.5
trap
or
less than 2.5. Okay.
Yeah.
Yes.
Love.
Otherwise, you can take an ox balloon of 2 millimeter, then you go high pressure
2.5?
15.
2.5.
Can make
Negative.
almost it will look like a 2.5 that time. But sometimes, you know, ox balloon, when you take, when you have a crusade inside, it will be difficult to go inside. What you can do is, you can take the wire inside the balloon and keep it
Trap.
straight and then push inside.
Dr.
Trap.
Ramdev again is talking about the dock exchange that
Pressure
we used to
is
use.
down.
But I think Dr. Ramdev, now I think most of us have moved away from dock to wire trapping. It becomes so much comfortable. You are in control as an operator, unlike a dock exchange where sometimes your fellow or someone who's helping you out may pull it out. So I think most of us are more comfortable with a wire trap rather than a dock nowadays, and it also saves the cost, I believe.
After still, we can use a nando technique provided your microcatheter and the wire are very neat. Then you can easily use an nando technique provided you know the technique properly.
Right.
But even I will advise better not to do nando, better to use a balloon trap. Goel sir, the first wire is actually gone little proximally. I think.
No, it is okay. It's okay, but it is there as long as it is. Now I have 2 wires here. Now one wire is more inside, so this is probably the PLB. Let me just say, deflate. Deflate, please. Deflate. Kar lo deflate. I'll take it out. Just hold on.
What happened?
No. I'm just exchanging the crusade out. So now I have the 2 wires. Now I have to identify. So this one is more out. So this one more out.
Longer wire.
The shorter wire would be there.
This is more out. So this is the PDA.
More out wire is the first wire.
PDA side branch, put it with the gauze piece. Side branch, gauze piece. Main branch, not wet, dry. Wet takes a weight and it will have it fall. Dry gauze. Okay.
So again, I mean, this is like you've learned in bifurcation when you're using multiple wires and all these CTO things, is to make sure you know how to separate your wires, and especially your colleague who's there with you also knows the wires. Yeah.
Give me a torquer here.
Actually 90-degree angle after.
Give me a torquer
because
here.
so that I will not be safe, you know. Don't keep both the wires together in one space. You just keep in 2 different planes.
No. What I do for these 2 wires, I have a principle, but that's my principle. Put a torquer on the main branch wire and a gauze piece on the side branch. I will always remember. Everyone will know it without. Anjo, please,
No,
come on.
But our assistant also should know which wire is actually with the torque.
Come on. All right, so it is done. So now they can complete the case. Give me a 2.5 or 3 balloon. 2.5 balloon.
Without an IVUS, what will be the size of the stent used?
2.5 balloon.
Preferably, I will tell it will be a minimum 3 millimeter or 3.25.
So this is the main branch. Like 2.5 balloon, please.
What will be the size of the stent to be taken, Goel sir, if you are not doing IVUS?
Sorry, I didn't get the question. What did you say?
If you don't do an IVUS, what will be the size of the stent will you take?
In this, I will take at least 3. At least 3.
This is
This
very
balloon
important.
is gone. One more balloon.
Yesterday also Dr. Shaiban was telling every RC
Actually, Pratap, you should we should read one of my publications which has just come up in the Indian Heart Journal, which correlates the angiographic size to the IVUS size of left main, osteoproximal LAD and osteoproximal circumflex. I have done it in left main cases. So, but the logic will stay in most of the vessels. And it is giving us a straight line equation, y is equal to mx plus c. So the equation is for the 3 is slightly different, but practically I'll tell you what it is. It is the true size is 0.75x plus 1.05. Now you can understand that. But I'm making a rough thing out of it, but there are 3 equations which I have published there. So 0.75x means if my, like this looks like the guiding catheter size. So you say it is 2. 0.75 of 2 is 1.75 plus 1.05 is 2.85. So the true size is at least 2.85. You get the point? So that is a calculation that we have got, and that I just published. It was something with me long time, but we got it analyzed and.
Luckily, medical doctors are not good in mathematics, so you can publish anything. We will read it.
Y is equal to mx plus c, the straight line equation. Everyone should know that. That much physics you must know. I am a physics guy. Yeah. I do medicine with physics, and CTO has a lot of physics. I can tell you, it's a lot of physics.
I know that. So I'm just telling. I'm joking only, but you are even that the retrograde. You know that I was guy that puncture. You just told about the mathematics, and it was wonderful. You know. I always tell everybody that he's a mathematician cardiologist among cardiologists.
Down. You've taken such a short.
Now, actually, after it's a very important point. Before putting a stent, he is dilating the other new wire that in the distal part, so that he wanted to keep the space perfect. Sir, Goel sir, will you put a stent into the PDA or PLV now?
I will put it into the PLV. I think PLV is the main branch. You know, down. It's like a bifurcation. So
you keep it provisional to the PDA.
I think I'll. Because there was there was not much disease at the mouth of the PDA actually at that point. That's what I thought. Because they were linking, you know, in the contralateral injection, the two were linked together. So that means the mouth of the side branch doesn't have that much of a stenosis. So let us do it to the main branch. That's the logic.
These are all important points, so people should understand that in the operative.
Actually, my everything works around the angiogram. I am angiogram man and a physics man. I told you. Rest all is.
So you will be called as the angiophysics man.
Yes. Let us have a 48 millimeter 3.
Actually, we wanted to finish it because of your interesting discussion. We are just holding on.
Chaliye.
You will be getting a flight. I have to also get a flight.
I am looking at the watch, at the clock.
No problem. Actually, after any more interesting questions you wanted to ask him, you can ask.
Yeah, so I think nothing more in the
348
in the chat box, except for Dr. Ramdev, who's been pretty active since morning. Yeah, again, the question of nitrates, I think we've already discussed. We don't want to give nitrates to grow this vessel. Despite giving nitrates, sometimes even at the end of the procedure, after you put your stent, the distal artery would look a bit
otherwise
not dilated, it would look undergrown.
Do it from the top.
You don't so much worry about the distal artery as yet, as long as you don't cause a distal dissection. And that's important sometimes when you oversize your vessels angiographically. So you may look at this and say that it's a 2.75 vessel. And you're taking a 3 or a 3, one has to be careful in making sure that there are no edge dissections, and probably
certainly.
I guess at the end of the procedure will help us to know that.
But after actually it was a wonderful show of antegrade wire escalation nicely. And he was changing wires nicely from the softer wire to the tougher wire. Here, people may try to use the tougher wire as the first wire in choice in these cases, but he did not do that. See, it is a systematic way of doing is always better. He was showing the people that. And moreover, you just see the positioning of the stent. He does not want the stent the position only from the CTO part. He wanted to keep the proximal part of the cover.
Come on. 1 second, sorry. Angio, please, come on. Okay, so thoda aur piche karenge.
Correct.
We'll have it little more behind. Test, please. This looks okay, huh? I'll pull out the side branch wire then.
The science or it is a synergy?
This is synergy actually. 348. 348. 348. Yes, stent. This is stent?
This is stent. No. This is stent, sir.
You have already connected it.
Correct.
Angio, please come on. Thoda sa aage
Thoda sa aage, that's what I also think. Because it's a marker, it's actually inside.
I think this is fine.
Very good. No. I think it is very good.
It is okay. I am beyond the bifurcation, na?
Yeah, correct. You are okay.
ये कैसे चलता है मुझे मालूम है. चलो. भैया मेरे को जो मालूम है वो मालूम है, जो नहीं मालूम नहीं मालूम. Test.
That is the advantage of all the great people, you know. They will always confess what they know, what they don't know.
चलो. 4.
Ramdev, are
Four,
you
sir.
okay?
Haan,
Questions
four,
or
four.
you have questions? Ramdev can ask some
6.
questions again.
6.
Ramdev,
Dr. Yadav, your inputs and
8.
your
Come
insight.
on, 8.
Yadav.
8, sir.
R.D. Yadav.
10.
Everything is fine. The only thing is that stent might need more post dilatation with the might be.
देखते हैं.
R.D. means questions will be there. When R.D. is there means always we are
Down.
happy.
Down,
One
down,
person
down.
will
Negative.
be-
हाँ. Yes.
He is having this many doubts.
No, I think RD asked those questions for the benefit of the other guys who are around.
I
So
know,
I
I
have
know.
no doubt that he
I
does.
was joking. One of the most intelligent cardiologists in the country. He reads everything. He's a total cardiologist. Not like the many cardiologists like me, not knowing EP in depth and all. He is a very good cardiologist. He knows everything. I personally feel that he does everything
Okay.
in cardiology.
Ready?
Yes, sir.
Come on. Inject. Oh, beautiful, huh?
Wonderful. And actually, you kept a good case for me.
सही है. It looks good, yeah.
After
I never expected it to look so good, huh?
No. I was
No,
actually
we had great expectations, I think. Yeah.
I was actually telling Dilip this will be wonderfully done by Goel sir, and he will keep a very good case for
Chalo,
me.
okay.
A simple.
You want to do some post? It's okay, I think. Do you want some post dilatations or you think it's okay? I think it looks okay.
But
I
I
think
want
the proximal part may need some post dilatation.
I personally feel it is nothing is required because we wanted to stop the.
I think
plans.
let us call it a day. Huh?
Long stent, I think it must be post
Are
dilatation.
you? Let us see in the other view also. My biplane concept. Other view. Are you? So you will see the division of the OM origin of the that PDA here better. Come on, inject. ठीक है. So now you see the origin of the PDA also good. I think it's fine. It's perfect. I don't think we
Very
need to
good,
do
very
anything.
good. I personally feel there is nothing is required.
Nothing. I have pulled out the wire. Okay. That's everything. is fine. Before you tell me anything else to do. And this sometimes when you pull back the guiding catheter, you bloody produce a dissection.
You
So
should
when
tell
I
it is
pulled
a-
it, when I pulled it out, I rotated it anti-clockwise and then pulled it out smoothly, so that it is out of the mouth and then out. You understand?
Yes.
Because here I have made it coaxial and put it in, so I have made it more clockwise and pushed it. So when it jumps out, it can scrap the mouth. So rotate back and out. Okay? Thank you. Complete. Thank you, भैया. मैं चला.
Actually, Dr. Goel sir, Anand Shukla is there to ask some questions to you.
आनंद शुक्ला हमारा वाला. Oh.
अरे वाला. Your person, man. You are.
वो हमारा बंदा है.
आनंद-
हाँ भाई
आनंद-
आनंद कैसे हो? आनंद
So Anand has asked about a proximal stent redilatation.
proximal stent.
Yes,
Post
sir.
dilatation, I believe.
Sir, great performance and great
By great to listen to you, and great to have you there. That is more important.
No,
Bolo.
sir.